can very vividly remember back when I was a resident having a patient that presented with cognitive decline and seizures. Now we sent off a whole bunch of investigations to try and find the cause, and eventually the LGI1 antibodies came back and we said, hurrah, we found the diagnosis, and we started treating the patient. Now that I'm a neurologist with specialized expertise in encephalitis, I always look back on that case and I think to myself, we probably could have treated him quicker. Instead of waiting for the test to come back, we probably could have identified this patient as having an encephalitis purely based on the clinical history and the exam without waiting. And I've certainly become a lot better with this over time. And today what I want to do is give you a masterclass on how to approach autoimmune encephalitis and very much a syndromic approach. Now, I posted a previous lecture on infectious encephalitis, and this is the flip side to that lecture, where in that lecture we talked about infectious causes. Today we're going to talk about autoimmune causes. And given that this is a masterclass, I'm going to presume that you know some level of understanding of encephalitis. If not, don't worry, we've got lots of courses and things to teach you about the basics. But for today, let's go into a masterclass on how to make a differential diagnosis for autoimmune encephalitis. We're going to follow this as a syndromic approach, exactly the same as we did previously with the infectious diseases lecture. And so when somebody presents with an autoimmune encephalitis, what I like to do is I like to split it up into the way they've presented and what the syndrome is. Because the nervous system isn't just one gigantic body of neurons. There are specialized neurons and there's specialized aspects to every part of the nervous system. And so certain parts of the nervous system carry specific proteins on them that can be more reactive to antibodies compared to other aspects. So rather than thinking of autoimmune encephalitis as one giant monolithic entity, we need to think about it as affecting different regions of our brain. When we see that particular pattern, then we can narrow our differential diagnoses down. We're going to go over these following areas. Now, before we even start, we need to talk about the Graus 2016 autoimmune encephalitis diagnostic criteria. For anyone who has any sort of interest in this area, or if anyone wants to know how to diagnose this properly, go and read that article now. The PMID is down there below. If you're too lazy to do that, just Google Graus Autoimmune Encephalitis 2016 and that'll come up. This is the Bible. So when I'm on ward service with the residents and the registrars, I literally see a patient, I pull up the criteria in front of us and we go over it every time to make sure we make the criteria. Let's do this in a simplified approach. So to begin with, when a patient presents, the first question you need to ask is, do they possibly have autoimmune encephalitis? And the major criteria they need for that is whether they presented with subacute onset, and we categorize that as less than 3 months of rapidly progressive working memory deficits, which means short-term memory loss, altered mental status, so this could be someone who has become confused, disoriented, or this someone with psychiatric symptoms, so things like psychosis, delusions, hallucinations. So you have to have that. Then you need to have at least one of the following, and that is focal neurology. So I've got a new hemiparesis, I've got a facial palsy, a sensory loss. So some sort of focal neurology we can find on the neurological examination. They need to have or new onset of seizure activity in someone who's never had seizures before. And we want to see some form of inflammation, and that can be a lumbar puncture demonstrating an elevated white cell count, or we have an MRI that is in keeping with what we would typically see with an encephalitis, and we'll explain that as we go through. And this is the most important aspect. We want to exclude alternative causes. If somebody has come in and they've overdosed on every single medication known to man, and they're out of it, they've got altered mental status, they're therefore dropped their GCS, and they've got seizures, well, that is not going to be an autoimmune encephalitis because you've just taken the history that they've overdosed on every medication known to man. So you need to exclude other causes first. So don't just presume straight away that this is an autoimmune encephalitis. So this is a possible criteria. So somebody comes in, if they do not even meet these criteria, then you could probably take a step back and say, this is unlikely to be autoimmune encephalitis. This is literally monopoly. Do not pass go, do not collect $200 if you do not pass this criteria, this initial passing block. And so if somebody's presented with short-term memory loss, but it's been 2 years, well, it's probably going to be more neurodegenerative or something along those lines. So the history is really critical here in trying to figure out what that time course has been. If this is successful, we can move to the next level to try and figure out if someone has a probable autoimmune encephalitis. And so it's the same features where number one is that rapid subacute onset, less than 3 months. We want to exclude other syndromes, which we will talk about in this lecture series, like limbic encephalitis, Bickerstaff's encephalitis, etc. So they don't have something else that's, slam dunk as a diagnosis. We can kind of add that to number 4, which is excluding alternative causes. And then we want to show some level of inflammation in the central nervous system, because if you remember, there's encephalopathy, which is just drop in GCS, or, you can either have encephalopathy, which is to do with alterations in consciousness related to anything, so metabolic, drugs, toxins, stroke, whatever it might be, versus encephalitis, which is inflammation. So let's find the inflammation. So what's the inflammation? Is it a white cell count that's elevated? Is it an abnormal MRI that's in keeping with encephalitis? Or have we literally taken a little bit of the brain and we can see inflammation that's there? So we would call that a encephalitis if we can see 2 of those being positive. So the MRI is abnormal, we do a lumbar puncture, and there's white cell count elevation there, and we've ruled out other causes, and they're presented in 3 months with, either short-term memory loss or psychiatric symptoms. That's encephalitis. That's probable autoimmune encephalitis. And that is really good enough to start treating before the antibodies come back. And the important part of the Graus criteria is that we don't have an over-reliance on antibodies. You don't need antibodies to treat early and diagnose. Antibodies are the icing on the cake. Once you get them back, then you can say, look, this patient has LGI1. This is the best treatment options for them. This is the prognosis. This is the long-term consequences, etc., etc. But just to make the diagnosis and start treating, you don't need any of that at this stage. So what are the actual mimics that we think about? And we should always think about these mimics at the back of our mind. So septic and metabolic. So again, if somebody's come in raging fever, they're septic, and they've got a drop in their GCS and they're confused and disoriented, well, that's probably related to that rather than autoimmune encephalitis. Metabolic, I always put things like hepatic cirrhotic liver disease, and we've got a high ammonia, and that can cause an encephalopathy. Drug toxicity, always think about it. Strokes can do it. Tumors, functional neurological disorders. I've had a couple of cases that I thought were going to be autoimmune encephalitis, but ended up being Creutzfeldt-Jakob's because of that rapid progression that they can develop. Epileptic disorders, rheumatological disorders, and then mitochondrial disorders can present very acutely and rapidly. And I saw one case that ended up being MELA. So now we're going to go into meningoencephalitis. So this is the first branch point. Somebody presents to hospital, they've got that kind of criteria that we talked about. You do an MRI scan, and they've got a meningoencephalitis. They've got meningeal inflammation, and they've got parenchymal inflammation, so meningoencephalitis. If we look at this MRI scan, you can see here at the brainstem, you can see that white rim around it. The leptomeninges are inflamed, and you can see it's even at the tip of the cerebellum there. So we will call that a basilar meningitis. I talk about that in a little bit more detail in the infectious lecture. So let's do a case. We've got a 48-year-old woman, 1 year of dizziness, left-sided weakness, amenorrhea, presents with headaches, generalized seizures, psychosis. Now she's got 62 white cells on a lumbar puncture, elevated protein, and a slightly low glucose. Interesting, 1 year of dizziness, and then she develops this left-sided weakness and amenorrhea. Again, a little bit atypical for autoimmune encephalitis, but if we look at the MRI scan, you can see very clearly here, there's very bright hyperintensity in the limbic systems and even in the frontal lobe as well. So we've got bilateral temporal involvement. We've got decent amount in the frontal lobe there in the cingulate region. And so if you were to take this at face value and just look at it right there, you would say this looks like autoimmune limbic encephalitis, and we'll talk about that in one of the next syndromes that we get to, that there's clear bilateral limbic involvement. This patient's got a white cell count elevation as well. But this is where contrast is incredibly important. So if we do an MRI with contrast, you can see there's all this nodular, chunky contrast enhancement all around the meningeal area on the periphery, and it's spreading in. Okay, so it's kind of outside in, chunky nodular stuff. Now remember the last lecture, whenever you see meningoencephalitis, you have to always think infection above everything else, and you have to rule out infection because infectious causes are the most common causes of meningoencephalitis. And specifically with the basilar meningitis, we always think about TB, and we also think about nodular enhancement. And so this is looking like a TB fungal kind of infection. However, 1 year history, it's a little bit too long, okay? There's not many people walking around with TB like this after a 1 year history. So we do an MRI scan of her spine as well. And if you can see here, she's got this longitudinally extensive transverse myelitis, but look at the contrast pattern. Again, we're getting a lot of contrast enhancement here. And you can see that there is this dotty nodular pattern around the meninges, but inside as well. And we call that a perivenular or kind of perivascular pattern. It's almost around the veins themselves and how you would imagine the veins and the capillaries to look like. So this is a very distinct contrast enhancement pattern. So the first thing to say off the bat is if someone presents with a meningoencephalitis, they do not have the run-of-the-mill standard autoimmune encephalitis cases. They don't have NMDA, they don't have LGI1, they don't have MA. All of those conditions do not present with a florid meningoencephalitis. They don't present with a meningitis. They just don't have a meningitis component. So as soon as you see a meningitis component and your autoimmune differentials kick in, this is the general list in my mind, in my differentials, that I always associate with autoimmune causes of meningoencephalitis. And you can see there's a couple here that have a specific quote-unquote autoimmune encephalitis feel to them, but the vast majority are not. They're different conditions altogether. And so in the comments below, tell me if I've missed something, because this is my own list that I've developed over many years. I'll put it as an Instagram carousel as well if you want to just copy it to your system, whatever you'll save it. But essentially here we've got a couple of conditions. First is GFAP astrocytopathy. So this is a condition, it's autoimmune, presents with a meningoencephalitis. Classically, people think about this radial pattern again. You can see this radial pattern here, this perivenular pattern coming out. And so people often associate GFAP with this. This only happens in 30% of GFAP cases, so it's actually not something that's that common. It presents with this kind of smooth, linear-like contrast enhancement pattern. But you can see this kind of perivenular pattern in neurosarcoidosis, in vasculitis, in lymphoma as well. So it's not specific nor sensitive to GFAP. The next one's neurosarcoidosis, and that's a classic one that presents with the meningoencephalitis. It's classically a nodular pattern. Remember, if we see that nodular enhancement, we're thinking granulomatous inflammation. All the ones that are colored in orange, those cause granulomatous meningoencephalitis or granulomatous inflammation and contrast enhancement. Whenever you work someone up for neurosarcoidosis, you should always work them up for CVID at the same time. So IgG, IgM, IgA, and we're looking to see if there's a deficiency in IgG and IgA, and that's because very rarely CVID can also present with granulomatous inflammation and causing this meningeal pattern. MOGAD can cause a condition called cortical encephalitis, where they get this contrast enhancement peripherally in the leptomeninges, and they can get thickening of the cortex, classically seen in T2 flare. And then CLHL11, KELCH11, is an autoimmune syndrome that presents with a testicular seminoma, and patients can present with a brainstem rhombencephalitis pattern, and sometimes they can also get this granulomatous inflammatory pattern as well. SUSACs, which is the classic brain, ear, and eye syndrome, they get branch retinal artery occlusions, they get sensory neural hearing loss as well, and they can get leptomeningeal enhancement alongside the corpus callosum lesions. Voigt-Koyanagi-Harada syndrome, and for everyone who is learning out of this lecture, you cannot abbreviate that to VKH. It must be said as Voigt-Koyanagi-Harada syndrome, because that sounds just super cool. These are patients that initially they present with ocular involvement. So they get serous retinal detachments, they get uveitis as well. After that, they develop a meningitis, and then later down the track, they get what we say is poliosis. They lose pigmentation in their skin and their hair as well. We think it's an antibody against melanocyte, and it's a very rare condition. It generally happens to people who have pigment. For some reason, KELCH11 has turned up twice there. And then we think about the rheumatological conditions. So lupus, rheumatoid arthritis, they can present in this manner, and then Behçet's disease as well. Now, what are autoinflammatory conditions? Autoinflammatory conditions are different to autoimmune conditions. There's two arms of the immune system. We've got the innate immune system and we've got the adaptive immune system. The innate are macrophages, neutrophils, dendritic cells. The adaptive are things like B and T cells. Now, autoimmune conditions to do with the B and the T cells. These are patients who we say have polygenic risk, so they have multiple genes and usually HLA patterns that lead to them to have autoimmune conditions. And so usually these are things like multiple sclerosis, lupus, rheumatoid arthritis. Autoinflammatory conditions are usually what we say is monogenic. There's a single mutation or a single gene that's gone wrong, and this codes for pathways to do with how the innate immune system works. And so what can happen is they can get these episodes of cyclical inflammation, fevers, CRP or ESR elevation. And we think about these in pathways like the inflammasome pathway, the C-Sting pathway, etc. Now, the classic prototypic one is familial Mediterranean fever. However, there are lots of conditions that can present neurologically secondary to problems with the innate immune system. The classic one is cryopyrin-associated periodic syndrome, CAPS, which is due to an NLRP3 mutation. And so these patients can present with recurrent meningitis, recurrent encephalitis due to autoinflammatory dysregulation, and this can cause a meningitis. Classically, we see a very high polymorphonuclear count. Why? Because the innate immune systems, your macrophages and your neutrophils, are being overactive, and so that's why the lumbar puncture can look like a bacterial meningitis as well as them having meningitis as well, and they can actually have a lumbar puncture that shows no bacteria, high polys, and they've got an autoinflammatory condition. So I think autoimmune, these causes, and then autoinflammatory, if I specifically see recurrent episodes, systemic inflammation, and an elevated poly count in their CSF. Obviously, I would treat them and work them up for infection initially, but if it's happening again and again, I think autoinflammatory. So what do we think about? Look at the contrast enhancement first. Look at if it's a basilar meningitis or not. Look if it's nodular or smooth. Dropped an H there. Look for autoinflammatory conditions as well. So the classic things we think about is urticaria, hearing loss, joint pain as well. And look at your eyes and your joints, and that's to look for things like Voigt-Koyanagi-Harada disease, Behçet's, even CNS lymphoma that can mimic in these presentations. And the vast majority are not on your standard immune panel, so you have to be thinking outside of the box, specifically when you see meningoencephalitis. This is the classic GFAP pattern we talked about, but we can see that in other causes as well. Limbic encephalitis. So let's do a case. We've got a 37-year-old female, focal seizures, 6 weeks of memory loss, temporal seizures, personality change, very high white cell count, 160. PCR for herpes is negative. OCBs, oligoclonal bands, are present. So if we were to just go based on the possible diagnostic criteria, 6 weeks is less than 3 months of short-term memory loss and personality changes, tick. So we've met a major criteria. Now we need one of the following. New temporal lobe seizures, tick. Pleocytosis, tick. So we've already said this is very likely possible. Let's see if this is probable. If we look at this MRI scan, look at those hippocampi. Now, if I need to teach anyone where the hippocampi are, that's where they are. Bright, white, right there. And it starts all the way at the front and it makes its way down. And the heads are just so bright. Now, compared to HSV, which we've done in a previous lecture, there's not a huge amount of mass effect. There's not this huge amount of edema. And it's very restricted, very restricted to the hippocampi itself. We're not seeing it move out into the amygdala or the insula or spreading out. It's very restricted. So this is the typical pattern we see with an autoimmune encephalitis, and very specifically a limbic encephalitis. So this patient ended up having a GABAB receptor antibody that was positive. But if we look at the probable diagnostic criteria, this patient has 6 weeks of memory loss, they've got new seizures, they've got an elevated white cell count, they've got an MRI that's very typical, so this would definitely be probable. And so this is where the next part, where I talked about, the exclusion, if you remember in the probable criteria, it said we need to exclude and make sure we haven't got another better diagnosis. And the better diagnosis in this patient is limbic encephalitis. As part of the Graus criteria, you can make a definite diagnosis of limbic encephalitis in this patient without any of these antibodies coming back. I don't even need a GABAB coming back because this patient had subacute onset of working memory and psychiatric symptoms. We had bilateral MRI flare. We restricted to the medial temporal lobes, like we showed you there. They had a pleocytosis, and this patient had temporal lobe seizures. We put the EEG on. They had clear temporal lobe by multifocal temporal lobe seizures, and we've excluded other causes. The HSV was negative. And so at this stage, this patient is a slam dunk definite limbic encephalitis. So not even probable, this is definite limbic encephalitis. And the icing on the cake is the antibody that's come back positive. But I do not need that antibody at all to make the diagnosis and treat this patient. Obviously, we want to rule out infections. We want to rule out all those other mimics that we talked about. But in this sort of situation, if the herpes comes back negative, and again, herpes is going to be very unlikely for 6 weeks of onset, right? And again, HSV negative, I'd pulse this patient with steroids straight away. No doubt about it. So if we think about what are the differential diagnoses for patients who present with a limbic encephalitis, we've got what we say a cell surface. And so these are antibodies against the surface of the cell. And these are usually B-cell mediated autoimmune conditions that can be very treatable and potentially reversible. And then we have what we say are onconeuronal. So these are paraneoplastic antibodies, usually driven by a T-cell mediated condition that, T-cells cause cytotoxic damage and cell death. And usually these are not very reversible and can have a poor prognosis. Based on the standard panels, which are the Euroimmune panels that are out there. So we're not talking about the fancy Mayo panels that have every single test known to man. We're not talking about the fancy Oxford panels, but we're talking about the standard one that is in kind of all over the world. These are the ones that are on panel, and the ones that are off panels are the ones on the right-hand side here. So you kind of have to think about those ones. So LGI1, Caspar-2, AMPA, GABA, and NMDA, the classic B-cell ones that cause limbic encephalitis. HU is probably the most common one for onconeuronal, and we can see it in MA and rarely in GAD as well. Okay, so this is the Graus definite limbic encephalitis. Now let's look at this case. So this was a patient of mine. He was about 70 years old. He went splunking in a cave in Romania, came out, and then went into status epilepticus, constantly seizing. Came out of the seizures after he was given lorazepam and anti-epileptics, and went to ICU, tubed, and they finally extubated him. Whatever, he was awake and not seizing anymore. He had a lumbar puncture which was bland, completely bland, and he didn't have any sort of weakness or anything along those lines. So he didn't have focal weakness, but he had new-onset seizures. And on history and kind of talking to him and examining him, he had some level of mild cognitive dysfunction. It was not quite clear. If we did the testing, there was cognitive dysfunction, but it's not quite clear how long that had been going on for. So maybe he met criteria 1 of the cognitive dysfunction. He's got new onset seizures. So he's certainly in the possible criteria. This is his MRI brain. So you can see here in the left hippocampus, we've got hyperintensity there. And you can see on the right side on the T1 with contrast, there's a little bit of contrast enhancement there as well. It's a bit patchy throughout the lesion. Now, there's a couple of little things that make me a little bit... The first thing is, look at that mass effect. That's a very swollen hippocampus. It's pretty swollen. And generally, we should not be seeing significant amount of contrast enhancement in patients who are presented with a quote-unquote typical autoimmune encephalitis, so your LGI1s, etc. That GABA case I showed you had no contrast enhancement at all. So there's a few things that are slightly atypical for me here that I'm not quite comfortable with. There's no pleocytosis, but he still could be a possible. But this is important where we think about excluding other causes. And so this is his repeat MRI scan, and you can see that it says massively exploded. This was about 2 or 3 weeks later. And you can see that it's massively exploded. That's chunky contrast enhancement. Unfortunately, this was a glioblastoma multiforme. And this is not uncommon. I've seen about 4 cases now of patients who presented with quote-unquote query limbic encephalitis, and it's been some sort of malignancy, primary central nervous system tumor, that has mimicked that presentation. So always think about your mimics. Let's think about cortical and white matter lesions as well. So we've got 55, progressive cognitive decline, 3 weeks of seizures. So that's our kind of first criteria of entrance. We've got an elevated white cell count, and so we're thinking this is a possible autoimmune encephalitis, and he's got a PET CT that shows a thymoma. This is not his MRI. I wish I had actually saved it, but I don't. So this is just the reference below. But let's look at this. We've got white matter involvement with the subcortical regions. We've got cortical involvement as well. And so you can see that some of it is very wedge-shaped, very patchy, fluffy. There was almost no contrast enhancement with this, and it's kind of a little bit all over the place. So when you see this, you just need to think straight away that this is usually one sort of problem. This is GABAA. So GABAA is generally not on your standard panels. It's usually a research test. But whenever you see white matter that's cortical and subcortical, think GABAA. My differential for this is hyperammonemia. But really, in this situation with the subacute onset, etc., you need to be thinking about GABAA. Sometimes we can see this pattern with MOGAD. And remember, if I talked about MOGAD before with the leptomeningeal enhancement, you get something called cortical encephalitis. Another term for that is flames. And with flames, and this is an example of flames, we have patients with this leptomeningeal enhancement. So again, you see the leptomeningeal enhancement, you have to think about the differentials I told you about. And we can see this thickening and swelling of the cortex on the FLAIR imaging that corresponds with that leptomeningeal enhancement. We can see optic neuritis there as well. And so in this situation, this is what we say is MOGAD, cortical encephalitis. Now, MOG antibodies are not generally, and again, it depends on which region of the world you practice in, on your standard autoimmune panels. So if you are seeing this pattern of cortex and subcortical matter, it's either going to be GABAA, which is not on your standard panels, and you think thymoma association with that, or it's going to be MOGAD, and you need, as another option, as another possibility. So Caspar-2 and DPPX, depending on where you live, can be on panel as well. But MOGAD is a separate test that you have to send. So always think about that as well. And then finally, we can also see ADEM present like this, but ADEM has its own presentation, contrast enhancement patterns, open ring patterns, etc. Whereas this is very much leptomeningeal enhancement or no enhancement. So cortical, white matter, think GABAA, think MOGAD with flames, and those are really those important ones we need to think about when we're sending off additional tests as well. Okay, Rhombencephalitis. Now, one more thing I want to mention as well before we move to Rhombencephalitis, I'm not going to go through cerebellum, and I'm not going to go through deep gray as part of the syndrome list that we talked about before, because those are generally movement disorders, and I'm going to do another lecture because that is a big lecture in itself about autoimmune movement disorders presenting with cerebellar ataxias as well as deep gray involvement as well. So let's talk about Rhombencephalitis. This Rhombencephalitis just means brainstem encephalitis. And so here you can see this picture of a patient of mine that's got these little maybe microabscesses, contrast enhancement pattern as well. But here we have a 45-year-old man, progressive depression, hypersomnolence, diplopia, dysarthria, sleep disturbance, huge amount of weight gain as well. On examination, he's got this upgaze palsy, he's got an elevated white cells on his CSF, and his PET scan is negative. So when you just look at this, what are you thinking about? I'm thinking about some sort of pituitary hypothalamus axis dysfunction, okay? Hypothalamic pituitary dysfunction of some sort. We've got the mood changes, the hypersomnolence, we've got the sleep disturbance, we've got the elevated weight gain as well. And then we've also got upgaze palsies and diplopia. So remember, upgaze is coming out of your midbrain. And so I'm wondering if there's some sort of brainstem abnormality as well as that pituitary hypothalamus axis. And when we see that, we need to automatically think about these conditions, and MAR2 is the big one we need to think about, okay? If any man is presenting like this, MAR2 is top of your differentials. I also think sometimes of Niemann-Pick type C when patients present in this manner. But we've got MAR2. MAR2 is a paraneoplastic syndrome. It's related to germ cell tumors in the testes, and patients can present with hypersomnia, narcolepsy, and they can classically get this upgaze palsy as well. The ones that I've highlighted in orange are the ones that also cause that hypothalamic pituitary axis dysfunction. So Eglon 5 is the classic one where these patients are presenting with parasomnia, sleep disturbances, and then they develop the brainstem and bulbar involvement. And they can also develop what looks like a PSP, a progressive supranuclear palsy syndrome with upgaze palsies. Caspar-2 can present with a lot of sleep disturbances and nightmares and hallucinations, and they can get peripheral as well as central involvement, and so they can get hyperexcitability on both sides of the spectrum. Anti-Re is a paraneoplastic syndrome that can present with jaw dystonia, opsoclonus, myoclonus as well. And then Bickerstaff's is a condition that is essentially in the spectrum of GBS, and we send off GQ1B antibodies for that, and the patients present with brainstem signs, decreased consciousness, hyperreflexia as well. Kelch-11, I'll talk about more when we do the autoimmune movement disorders because they present with a cerebellar-like syndrome. And classically, it's also germ cell tumors, and they develop a hearing loss as well. But in this particular syndrome, we're thinking brainstem, Rhombencephalitis, we need to think about these differential diagnoses. So takeaway points, MAR2, somebody presents in that syndrome, always think about testicular cancers because you saw here Kelch can do this as well as MAR2. In women with anti-Re, we think about breast cancer and ovarian cancers as well. And PET scans can miss testicular cancers, and so we need to do ultrasounds as well. Eglon 5, sleep is the big thing. REM behavior, sleep disturbance, parasomnias, and they also develop quite a lot of bulbar as well as ocular signs as well. CSF is often near normal. It can be elevated, and this is a very difficult diagnosis because it fits in that kind of spectrum of neurodegeneration. We'll talk about that. As per my other lecture, always think about Listeria first, please, and then Bickerstaff's we talked about as well. Okay, so I've talked about these beautiful Graus criteria, these beautiful rules of 3 months and do this and check your CSF, but there are outliers. Nothing fits perfectly within all of these. And so NMDA, how did I go through an entire talk about autoimmune encephalitis and leave NMDA to the end? The reason I use NMDA to the end is because it doesn't fit classically into any of these syndromes I described. It is its own syndrome. And again, part of the Graus criteria, they created this own syndrome. So just because somebody presents with autoimmune encephalitis and has a teratoma does not mean it's NMDA. Every person who presents doesn't have NMDA. NMDA classically, okay, and if we were to use this for the probable NMDA diagnosis, 3 months of at least 4 of the major criteria. And this is the classic syndrome they present with: psychiatric, behavioral cognitive dysfunction, precious speech, or reduced output and mutism. They can have seizures. Movement disorders are very classic. They can get dyskinesias from too much movement or rigidity. They can get this abnormal posturing. They can get this oral dyskinesias as well with their mouth. They drop their GCS. The classic one is autonomic dysfunctions, big fluctuating blood pressures and heart rates and central hyperventilation requiring intubation. So we want at least 4 of those. And then we want at least 1 of the following, and that's a lumbar puncture that's abnormal, pleocytosis, or oligoclonal bands, or an abnormal EEG. And the classic thing we see is we get diffuse, disorganized activity. You can have epileptic activity, and then we get something called delta brush, where we have this slow delta activity, and on top of that, there's this tiny kind of almost beta activity on the actual slow delta. So it looks like a toothbrush, essentially. You got a little bit of a brush there of high beta on top of the delta itself. So if we see any of that, and we've excluded other causes, so they're not on a ketamine infusion or something, then we've got a probable diagnosis. A definite diagnosis is when you get the actual IgG back and it's positive, the antibodies come back. Now, that plus 1 of these 6 symptoms. So if somebody comes in and they've stubbed their toe and their NMDA is positive, they don't have NMDA encephalitis, okay? They've got a stubbed toe and an incorrect test. Now, antibody testing with NMDA, and I'm not focusing on antibody testing, I'm going to do that at another time, but I'm not focusing on that because, again, it's a big lecture on itself, but we want CSF. It has to be CSF, okay? And for whatever reason, if only serum is available, okay, because, I don't know, for whatever reason, then it needs to be confirmed on 2 different tests. So either a cell-based assay and an immunofluorescent assay. So we want 2 tests confirming it. But if CSF is there, then it needs to be tested on CSF. And CSF has high sensitivity and specificity. There's a lot of false positives on serum, and we don't want to rely purely on serum. We want CSF. We want to exclude other causes. So that's NMDA. But it's also important to understand that NMDA can have a negative MRI scan in 50 to 70%, and in about 5 to 20% the CSF is negative. So we don't want to just think, oh, the MRI is negative, therefore it can't be NMDA. Now, what are the other 3 outliers? LGI1. LGI1 patients can have symptoms greater than 3 months. And that's the same with Caspar-2, and that's the same as Eglon 5. And this is why these 3 antibodies can fail with the possible and the probable, because they are longer time periods. Interestingly, LGI1 can also have a negative MRI and a negative CSF. So it's one of those rare cases where you can have a very kind of 6 months of progression as well as a negative MRI and lumbar puncture. Classically, LGI1 presents with the fatiobrachial dystonic seizures, where they get that little spasm for a few seconds and then it releases. It's a dystonic posturing, and they can have seizures as well. So if someone's presenting purely with cognitive decline, it becomes a bit harder to diagnose, but cognitive decline plus the fatiobrachial dystonic seizures and more seizures, it can be a little bit easier to say this could be LGI. These patients can still potentially hit the possible criteria. So let's say, as an example, we have someone who's presented with cognitive decline and seizures, but the cognitive decline is a bit longer than 3 months. I can still consider LGI1, CASPA2, or Eagle-on-5 as well. And we've talked about CASPA2, Eagle-on-5 we've talked about as well. Eagle-on-5 sits on the spectrum of what we say is a tauopathy, a neurodegenerative process, but if picked up early with some inflammation on the lumbar puncture and treated early, they could have good outcomes as well. And that's it. That's the whirlwind tour through autoimmune encephalitis. We're taking a syndromic approach. We're using clinical criteria. We're not over-anchoring on the antibodies, and we're trying to make that diagnosis early. Don't forget infections, don't forget mimics, and don't be too stringent when you need to think about other outliers out there like LGI, CASPA2, and Eagle-on-5 that can present in a slower manner. Now, if you absolutely enjoyed this, please subscribe, please follow along. We're going to do a combination of masterclasses as well as clinical neuroanatomy, where we're getting deeper and deeper till it does get super complicated. But if you have any suggestions of what you want me to teach you, please put it down in the comments below. If you want to understand neurology properly for the first time, build that foundation and then move on higher and higher, building on that structure that you've learned, then do check out our courses, because there's something there for everyone, because understanding foundations are critical, and then learning upon that really makes you an exceptional physician.